Thank you so much for the introduction. And thank you so much for the opportunity to come and speak with you all today in beautiful Rome. It's really a lovely honor. So I've been tasked with giving just a high-level overview of what options we have available for the use of, that we have use of for HIV prevention today. Here's a list of disclosures, some research funds to my institution for investigator-initiated studies as well as industry-sponsored trials, and salary support from a program called the Canada Research Chairs in Canada. So I'm hoping to spend most of the time just reviewing some data at a high level on regimens that are currently available for use as HIV pre-exposure prophylaxis or PrEP. I'll spend a few moments at the end just commenting on novel approaches and regimens that are available for post-exposure prophylaxis or PEP, and throughout this really underscore just the importance of having a diversity of options to support the concept of patient choice in making decisions that are best suited to them. So, of course, for many, many years now, we have known that PrEP exists and it works, and it has really been limited to the form of a pill for much of that time, but that's changing, of course. The basis of that is a series of clinical trials that were conducted over about 10 years ago now, mostly with the pill tenofovir disoproxil fumarate with emtricitabine, TDF-FTC, or known also as the trade name Truvada, which you can see from these data have been really well studied in a variety of different patient populations around the world, different settings, sometimes TDF alone, but typically TDF with FTC, clearly demonstrating efficacy compared to a placebo. So those point estimates for efficacy in the intention to treat analyses across these different trials are listed in the right-hand column. Sometimes folks who are less familiar with these data will look at those numbers and kind of be perplexed about why we're so excited about PrEP in our field, right? Because those numbers don't necessarily look all that impressive. But of course, we all know that one of the major reasons that those estimates weren't higher was because adherence to study drug in those randomized trials in an era where we weren't sure whether it worked and the alternative was a placebo was imperfect. So if you do meta-regression, such as done in this slide here, and you look at the degree of adherence with study product across the trials on the x-axis, and you look at the effectiveness as a function of that, you can see that there's a clear linear relationship. So we have been emphasizing for many, many years the importance of adherence to a PrEP regimen if we expect it to work. Now, that being said, shortly after those initial trials started to show these results, we also learned that at least in this setting, which these are data from large cohorts of gay, bisexual, and other minority sex with men, which I'm abbreviating as GBM, using daily oral TDF-FTC, we actually learned that even when folks have suboptimal adherence with that daily regimen, so if we look at folks who are only taking their tablets, say, 4 to 6 out of the 7 days in a week, we know what drug concentration of tenofovir diphosphate that correlates with, shown on the x-axis. And then when we look at HIV incidence as a function of that, we see that actually we still achieve excellent HIV prevention efficacy in effectiveness estimates, reaching almost 100%, albeit with a lower 95% confidence limit of around 86% at the bottom there, even when folks are having that kind of incomplete adherence with the daily regimen, really emphasizing that this intervention is actually more forgiving of incomplete or imperfect adherence than we might have otherwise suspected, and certainly much more so than antiretroviral therapy. So that's really encouraging information that I think we need to keep in mind. Now, the next regimen to come along was to use the same pill in a on-demand fashion, what we also call a 2-1-1 fashion. So just as a reminder, the way that this works is if a person predicts that they're going to have a potential exposure to HIV, let's say right here on Wednesday, today happens to be Wednesday, so it depends what you're doing tonight, you could take 2 tablets of the same product 2 to 24 hours before sex, followed by a pill the next day, a pill the day after that, and with that 2-1-1 regimen, that episode of exposure is now protected. And as you know, this trial was actually halted early for an early signal of efficacy, which is represented in this cumulative incidence function here. You can see that the overall estimate was of 86% relative risk reduction. And the only reason that that estimate isn't higher, closer to 100%, is because of two infections that you can see in a stepwise manner in the blue line there that occurred in the TDF-FTC arm in folks who actually told the study staff that they were not taking the study drug appropriately at the time of the incident infection. So really suggesting, once again, that this intervention has extremely high effectiveness and can be used in specifically GBM. Now, one of the limitations, I think, of those data for us for some time was that if you look at the frequency with which folks in the trial were actually using their 211 PrEP, they were taking a median of about 16 pills per day. Per month, I'm sorry. So if you do the math, that equates to roughly one episode of exposure per week, a fairly high frequency. And it's not surprising then that those data, those efficacy data from IPERGAY overall, map so nicely onto the daily data that I showed you earlier with that kind of traffic light color-coded diagram, where folks who were taking their daily PrEP but only succeeding in taking it 4 times per week also had excellent efficacy. And so it left in our minds some uncertainty, I think, about just how well this 211 regimen would work in folks with even less frequent exposures, say only twice a month, or maybe just once a month, or even less than that. So the IPERGAY investigators did a really nice job of trying to investigate this issue. They looked at their data and they said, well, let's look at the folks who had somewhat less frequent exposures, operationalized as taking 15 or fewer pills per month, so less than 4 episodes per month perhaps, systematically or often, meaning that they were adhering with that regimen. And in that subset of data, it's only about 134 or so person years of follow-up. They again see excellent efficacy. So that's great, but I think we still had uncertainty. What about even less frequent exposures, once or twice a month or even less? And unfortunately, we don't really have great data at this point directly assessing that. But what I do think we have is we've had the passage of time now. It's been several years since those trials were first completed, and we're starting to see more and more rollout of this intervention and hence more observational real-world data. Here are 2 examples of such data. There are others around the world. The left is a study from 4 cities in China. The right is from the Prévenir cohort in Paris. Both had very similar designs where GBM were explicitly offered both options, daily PrEP or 211 PrEP. People could choose between the 2 options, and they could change their choice over time as their lives dictated. And what you can see is that overall, we did not see differences in the effectiveness of daily or on-demand PrEP in this non-randomized comparison. So that's reassuring, again, reinforcing the fact that both regimens work. The Chinese study on the left actually had a concurrent arm that didn't take any form of PrEP by choice, and we see a dramatic efficacy there with both of the PrEP arms compared to no intervention. Within these cohorts, we have a mixture of people in terms of their frequency of sexual exposure. I think it was a little bit more diverse in the Chinese study, where there were folks who were having a fairly infrequent sex, perhaps just twice a month on average, at least at baseline, although it's not described in detail in the paper what happened over follow-up in terms of efficacy or effectiveness in the setting of infrequent exposures. But we certainly globally haven't seen a clear signal that 211 PrEP is failing very often. And so I think cumulatively now we're getting more and more comfort with this regimen in a diversity of situations. Certainly the COVID pandemic, in many people's experience, led to folks switching from daily PrEP onto a 211 regimen, and it allowed for more experience with this regimen. And so I think we're gaining comfort with this in a diversity of folks, regardless of their degree of sexual exposure. The next regimen that came along was, of course, TAF with FTC, so tenofovir alafenamide with FTC. This has been studied in the DISCOVER trial in a large group of over 5,000 GBM and compared head-to-head with TDF-FTC, designed as a non-inferiority study. And you can see here clearly that it met the non-inferiority criteria, perhaps a slightly numerically lower incidence, but clearly giving us comfort that this regimen is also an excellent choice for those who have access to it. And the clear advantages, as we all know, relate to the known occasional toxicities of tenofovir disoproxil fumarate in terms of renal and bone issues. So here are the data looking at hip and spine bone mineral densitometry changes at 1 year. You can see that it declined as predicted with the TDF arm, but did not do so in the blue TAF FTC group. So that's encouraging, and those differences are statistically and probably clinically meaningful at 1 year. Not to be surprised by why the numbers would actually go up in the blue arm. Remember that this is a relatively young cohort, so mixed in here are a group of younger GBM who would be expecting to actually be at a phase of life where they would be gaining bone mass as a function of just normal physiology at that age. Here are the renal data. So on the left, you can see serum creatinine changes. On the right, that's converted into creatinine clearance changes over time. As expected, you see modest steps in the direction we don't want in the red TDF lines, and then TAF arm in blue showing not a lot of change over time, consistent with what we already knew about this drug and its performance in the HIV treatment setting. The one difference that might, of course, be an advantage of TDF, which is not shown here, is in terms of some of the metabolic issues. So we do know that TDF, of course, is also a bit of a lipid-lowering agent. So this actually might be a preferred option in folks who have cardiovascular risk factors at the same time. There's also very modest differences in terms of weight after the first year of experience on the two agents, favoring the TDF arm, perhaps again because of that drug having a bit of a weight suppressive effect. So I think we have to be very thoughtful in our choice of option in folks who do have access to both of these in the setting of GBM. So clearly we've got some great oral options here. Many of us in the field had been looking forward to the emergence of a long-acting oral option, and islatravir had been looking promising for some time in that respect. Unfortunately, as you know, though, that development program, at least on the prevention side, has been halted because of the unfortunate issue with lymphopenia that we saw with that drug, and so it's not going to be progressing for further development as PrEP at this time, although it will be continued to be looked at in the treatment setting. Nevertheless, we do have other long-acting options for PrEP, and so we're in a really exciting phase of the HIV prevention movement right now. We've got already the existence of an intravaginal ring, as well as injectable agents. More of those coming in the future, we hope. And then even further into the future, we've got a nice pipeline of drugs that could be looked at as a long-acting implantable option, perhaps even long-acting monoclonal antibodies. And we've seen proof of concept with the AMP trials demonstrating that option could work in the future as well. But I'll spend a bit more time talking now about the options that do exist at this time, starting with the dapivirine vaginal ring. So these are trials that were actually published, of course, several years ago now, looking at a silicone ring that could be placed into the vagina on a monthly basis. It's impregnated with this non-nucleoside reverse transcriptase inhibitor, dapivirine, and demonstrated to have these, modest intention to treat efficacy estimates in the trial. If you do adjusted analyses where you look specifically at folks who had better adherence with the product, and in subsequent trials, this number can rise somewhat to something closer to about 60% risk reduction. But clearly a really important advance in the field because of this being a truly woman-controlled intervention. It can be placed in the vagina without the knowledge or consent of a male partner. Male partners typically were not aware of it. Those who were tended to indicate kind of ambivalence and hence acceptability of its use. And so this is a really exciting option for those reasons. Even though some may look at these numbers and be unimpressed with the point estimates for effectiveness, this has actually moved forward. So over 2 years ago now, the WHO had recommended this be advanced as an option for women, and it's moved through the European Medicines Association for approval. And why might that be? Here's one of the places I really want to emphasize this principle of choice and expanding options for folks. And it's nicely illustrated with this concept here that has been labeled, mosaic effectiveness. The idea here is that, even though it may be counterintuitive to some to advance options that are known to be less effective than a standard of care intervention, it may still make a lot of good public health sense to move forward with such a product because they can have population level impact if they attract new users. And we've seen this time and time again in other fields. There's often extrapolations or comparisons made between the PrEP field and the field of contraception, which of course has been a field of study for many, many years longer than PrEP. And here's a seminal paper from that field demonstrating that if we look here at the number of available methods for contraception that exist in a jurisdiction, in this case, each of the dots here represents a country. This is an analysis from about 10 years ago. And then on the y-axis, you plot the population level coverage with some form of contraception, of actual use. You see this nice linear relationship. And again, it really emphasizes the point that having more choices at all is associated with greater uptake. And if we can achieve that with PrEP, if we can create and promote options and put a real menu of viable options in front of individuals who at this time may be hesitant to use what's been put in front of them in the past, we may achieve better population level uptake. We may be more successful at making a dent in incident cases of HIV around the world. We've looked at this principle, and I'm showing you just a tiny little bit of data from our own group in Toronto, where we looked at preferences for different hypothetical, at that time, PrEP options in a cohort of GBM who are coming in for point-of-care anonymous HIV testing. So this is a population that would be at risk for HIV. We actually conducted what's called a discrete choice experiment to kind of look at and quantify people's preferences for hypothetical options, including a rectal gel, which of course we don't have at this time, an injectable, which at that time we conjectured might be available as a monthly product as opposed to the 2 monthly. That's become a reality that we'll talk about in a moment, as well as offering them an on-demand pill or a daily pill. And in the table on the right, I'm just demonstrating that we can calculate out of these data what the predicted uptake of these different options would be among these individuals at risk. And highlighted in red are the proportion of participants who would be expected not to choose any of the options despite meeting criteria for PrEP. And the key message is simply that that number goes down, albeit modestly, as you increase the number of options available. The amount, of going down from from having 2 options available to 3 options available is roughly, 4% or so. Going from 3 to 4, even less so, because the rectal gel wasn't terribly popular in this setting. Those numbers don't seem that impressive on their face, but once again, I think the important point is who are those, 4%, or who are those 0.2% of individuals? If those are folks who have a particularly high risk of acquiring HIV among all of these users who could benefit from it, I think it argues for the fact that we really do still need to make these options available because they may have a disproportionate impact on the prevention outcomes we could see. So finally, we do have another really exciting prevention option that's just become available in some parts of the world over the last couple of years, and we're hoping that that will continue to expand, and that's long-acting injectable cabotegravir as PrEP. And as you know, the HPTN 083 and 084 trials demonstrated this product, when compared head-to-head against daily oral TDF-FTC, is not only non-inferior for HIV prevention, but actually superior, 66% more effective than oral PrEP in this large trial of GBM and a considerable number of transgender women, 88% more effective when compared against daily oral TDF-FTC in cisgender women in various settings in sub-Saharan Africa. So how is it possible that you can possibly do better in terms of efficacy than a product that could reach 100% efficacy? Well, of course, it again has to do with the fact that we overcome the adherence barrier that we know exists with any oral product that requires sustained adherence behavior over time. These are the actual adherence data in the 083 study in GBM, and you can see that as the time points progress, the proportion of people following into the good area of adherence, that's the green bars, mapping onto those 7 days a week or 4 to 6 days per week data that I showed you earlier, that goes down over time. And hence, having a long-acting injectable that overcomes people's need to sustain that adherence behavior can be not only non-inferior, but actually superior in terms of preventing HIV. So really exciting to see where that goes in the future. Now, at CROI this year, we learned more about this emerging struggle, this emerging problem that's been given this catchy acronym, LEVI, or Levy syndrome, long-acting early viral inhibition syndrome. That's been now described nicely in a number of papers. And the point is that among the rare infections that did occur in CAB-LA recipients to date, specifically looking at those true breakthrough infections, people that were receiving their injections on time, what was apparent was that it would be easy to miss some of those incident infections if we were relying solely on traditional serology assays that look for an antibody response, which of course takes time to develop. In the presence of low-level concentrations of this drug, what can actually happen is that an infection could occur but be undetected because it's not been long enough at that low level of viremia to sustain an antibody response or to generate an antibody response. And not only that, you can occasionally see the emergence of INSTI resistance, which has implications for first-line treatment options, as we just nicely heard in the previous talk. So the implications for how this is going to be recommended for use in different settings is going to vary. It's been recommended that HIV RNA testing should be implemented in order to catch these, but of course that has resource and feasibility constraints associated with it. So this will be an interesting area for debate as we move forward. The time's just about up, so I'm going to just finish with a couple of quick points about PEP. What's exciting in this field is we're continuing to see the actual data generated on emerging options that we always predicted would work really well as PEP, but now we've got data to show it. Specifically, I'm showing two papers here, one in Beijing, one in Boston, looking at the use of bictegravir with TAF and FTC as a PEP option. Really exciting to have a single pill regimen that is not associated with drug interactions like Stribold or Genvoya might be. That has an integrase as its backbone. And you can see very nice levels of PEP completion. This is the most important clinical outcome measure in a PEP trial because we're expecting not to see differences in efficacy. But to see very high levels of PEP completion with a regimen is really a sign of, I think, its success and suitability for use in that setting. And then I wanted to finish with introducing you to a concept that has been around for some time but doesn't get that much attention, this idea of using PEP in an on-demand fashion. You know, traditionally we think of PEP as an intervention that in most settings needs to be accessed in a real emergency sort of fashion. Often it's actually through visits to urgent care or emergency departments, which is associated with stress and anxiety about whether it's going to happen or on time, whether the provider is going to be skilled and knowledgeable, etc. The idea of on-demand PEP is that we can, in an outpatient controlled setting, provide folks with an intervention, a prescription for PEP medications, and instruct them on when and how to use it so that they could use it if they anticipate that they would typically not have this happen, but have a fail-safe. Again, it interacts a little bit with the notion of on-demand PrEP, but given the uncertainties around on-demand PrEP in very rare exposure settings, or in folks who just don't think they're going to be reliably able to predict the need for on-demand PrEP, on-demand PEP could be another option. And the data on this go back to 2004 in Brazil in the upper left, where this was associated with a lower incidence of HIV when cohorts of GBM had access to it. In the UK, you can see on the bottom left a recent paper indicating that this was associated with a shorter time to the first dose, which is probably a really important indicator of the likelihood that this would work. On the upper right, we in Toronto have looked at this regimen and found that it's been associated with high acceptability, high feasibility, and has the advantage in folks who don't want to take PrEP of likely some cost savings and inconvenience or convenience benefits, I should say. And in the bottom right, some data from East Africa, Kenya, and Uganda, in which has been offered explicitly in a setting where folks could choose between different prevention options, and once again demonstrating that the availability of another option led to increased uptake of some kind of prevention option overall, because some people deliberately did not want to take PrEP for whatever reason. Privacy was one that some cited there. So I hope that gives you a bit of an overview of the multiple safe and effective PrEP options that we have today, emphasizing that there's lots of options that are available for PEP as well, including this notion of PEP on demand, and really underscoring the principle that whatever tools we have available, making more of them available to our populations at risk is really critical to increasing self-efficacy, the concept of empowering patients to make their own choices, and ultimately we hope population-level impact so that we can prevent HIV in more and more individuals moving forward. So with that, I'll stop and thank you so much for your attention.